on slit lamp where there are cells in the anterior vitreous which you can very easily see on slit lamp. And also with retroillumination, means the observation system and illumination system make it coaxially, then you will see the red glow, completely red glow you will see. If there is any alteration, so in detailed examination you have to do this posterior segment also, the moment you see that.
Message is that if you see cells in the aqueous humor, you must examine the anterior vitreous very carefully through slit lamp, dilate the pupil and make attempt to examine the fundus also to assess the involvement of vitreous. Now this exercise which we just said, Dinesh, do you think it should be done on all post-operative visits or certain days are important?
Yeah, see, obviously no patient can come every day for a follow-up. It's just not practical. So the important thing is, when does acute postoperative endophthalmitis occur? It usually occurs within the first 4 weeks after your surgery. Within that also, if you see, more than 80% of cases will occur within the first week or 2 weeks. So the ideal times for first day post-op is obviously the most important day, because you don't want an acute severe endophthalmitis to be missed. But after that, the 3rd or 4th day, and then again on the 7th day, and then subsequently at 3 weeks. But one more proviso: the patient should be told SOS also. SOS means any change for the negative. Any blurring of vision, any increase in pain, any increase in redness are indications that the patient must come immediately for a follow-up. So these are the situations where the follow-up must be done. So these days are the important ones.
Basically what happens is, normally the first day you call the patient, fair enough. If everything is alright, even if everything is alright, call the patient on the 3rd day. A lot of people are not calling them on the 3rd day. Sir, yeah, everything is fine, come. Normally they call them after 3 weeks, because when they are going to give glasses. But what he has said is very important, that during this period, if patient feels that his clarity in vision or the quality of vision is going down, he must report to you immediately. That is one of the most important things. Normally the patients from outside will say, nahi, thoda sa kam dikh raha tha, maine parwah nahi kari. By the time he comes to you, he has a full glown endophthalmitis. Now the basic point is, he has mentioned that red glow and all that. Dr. Lalit, could you please be a little more indulgent? I would like to know how important it is to have a look at the posterior segment.
For me, it is all patients have to be dilated, because eye examination without having a peep onto the retina is incomplete. I don't believe in half examination. If you are suspecting reaction, for a general ophthalmologist, as point was being made by Dr. Nayak and Dr. Dubey also, that any patient who has severe flare, for you to obscure iris or there are cells which you can identify, please dilate and see. It will require one peep with indirect and you will clinch the diagnosis. Endophthalmitis, in contrast to TAS, has to have exudates in the vitreous. So you have to see, dilate and see.
Continuing that, Dinesh, do you think that there is a system for grading the haziness in the vitreous and visibility of the retina to give you some directions for picking up the mode of treatment?
If you see the first slide, this is absolutely clear retina visualization. Now basically this is no vitreous haze is there in this fundus photograph. You come to the next one, you see the disc is visible, you see the second order vessels are seen, but there is a haze over here. This is now a mild vitreous haze has started. The next stage is when you have a haze which is obscuring most of the periphery, but the disc and the major vessels are still seen. So this is the next grade, that's grade 3 over here. And this is when you have, grade 2, and this is grade 3, where you can barely make out some details of the disc, but more, and there's a peripheral glow, but most of the areas are obscured. And this is grade 4, when there is actually no visualization at all. The important thing for us is, and you must know this, that once you come to this grade, you're not likely to have much vision also. Once you come to grade 3 and 4, the vision is likely to be less than counting fingers in these patients. Any patient who has this kind of picture actually deserves a vitrectomy. This picture onwards actually deserves a vitrectomy. The reason why he very often doesn't get a vitrectomy, and he very often doesn't get a vitrectomy, is because the vitreoretinal surgeon is busy with his OPD. So he says, okay, ऐसे है, आज injection लगा देते हैं, कल दे देंगे, कल surgery कर देंगे, which is not actually the ideal way of managing this patient. and it can compromise your results. Fortunately, it doesn't every time, so you get away with it.
The basic point is what we are trying to say is that you have to pick up your cases at grade 2. You see, that is what we don't want to miss the train. Once the train has left the station, then you do not know what is going to happen to the eye. So that is the basic concept of this course, that how do you detect these patients early and intervene early so that you can prevent vitrectomy from being done.
Lalit has a point to make.
In this case, I would insist interval injections.
Okay,
In these three, I do not hesitate to do early vitrectomy.
all right.
Fair enough.
Inferior witness and retinal exudation over the retinal vessels also need to be seen even in grade 1.
Yes. Sometimes you can have early exudates in the inferior part of the vitreous. So that is another thing which you must be careful about. You have a distant direct and you feel it's okay. It may not be okay.
Now, second thing, this is our observation.
बड़ी देर से बोल रहा है यार, उसको बोलने दे.
So if the patient has not of SP or corneal edema, then how will you...
We'll come to that.
We'll come to that. We have not
Come
finished
to
the
that.
course.
We'll come to that. Second thing, as vitreous surgeons, when we receive referral from phaco surgeon on an infected case, it is generally the record of visual acuity on first post-operative day is missing. Now, it is medico-legally important, and also it is important from viewpoint of assessment of progress or deterioration of the patient. I'll request comments from Dr. Nayak.
Actually, in each and every visit of the patient, the visual acuity must be recorded. And because what I see that on first day, suppose the first post-op day, whether first or second, whenever I see in the first time, if the vision is not say 6.9 or 6.6, then you must try to find out the reason for this. So that is the one important point, that why vision is not 6.6. The second is that in case if your first visit your vision was better, and the second visit when the patient comes, vision had dropped down, then again you have to be careful, then why it has dropped down. Again you have to find out the cause. So for these reasons, vision you cannot avoid. Every visit you must record vision with pinhole. You may not do complete refraction, but direct vision and with pinhole vision.
Lalit has a point.
I would still insist on complete refraction is possible. Then, very important point is, if suppose first day vision recovered to 6.966 and patient comes to me later with finger counting, but that should be recorded. That gives me confidence that this patient has a lot of potential. That if I do intervention, vitrectomy or this thing, this patient has vision potential to come back. That is the importance of recording vision at every visit, apart from medical legal aspects. You see, from medical legal, you have to save yourself from conviction.
Vitreous surgeon can extend prognosis.
Yes.
Another important thing which I like to add is that when actually an infection has occurred and you had made a record of visual acuity, after you give an intravitreal antibiotic injection, it is the first sign to recover. And therefore, you should have a base record on the first post-operative day so that you can scientifically document the progress of the patient.
Second thing, very important thing is that basically you should have these records well, because medico-legally this is very important. If the patient goes to the court, then you have to show them that, look, this is the way the patient is progressing. And in fact, I have been a jury on a lot of these investigations, endophthalmitis patients, and half the time the records are not available. So even if I want to protect the doctor, I cannot protect the doctor. Though I have a very strong inclination to protect a doctor. I don't want the doctor to suffer.
Except me.
No. So the basic point is that you should always keep your records very well. That is the most important point in every patient.
Now, this table I have adopted from a CME series which was authored by Professor Tiwari, Professor Lalit and Dr. Venkatesh. They were working in a quaternary center at that time, and they attempted to answer to that perpetual debate whether a reaction is inflammatory or it is infective. These three things attracted my attention. They say that when fundus glow is poor or absent, it is infection. When it is okay or mildly poor, it is inflammation. When there is 2+ haziness in the vitreous, it is infection. When it is clear or mild haze, it is inflammation. And when the color of exudates are yellowish, it is infection. If it is white, it is inflammation. I agree with them, but this actually description will not be relevant to current cataract surgery, which is microscopic, and also to the primary objective of this course, wherein we want you to catch these cases before the fundus glow has become poorly visible or absent. And drawing upon their idea, I attempted to make a guideline for post-operative examination by a phaco surgeon regularly, especially in cases wherein he is suspecting infection. If corneal edema is present, it can be inflammatory, infective or surgical. If corneal infiltrates are present, they are generally infective. If there is only flare, as we had demonstrated through that animation, it is inflammatory. If cells are present in anterior chamber, this falls strongly in favor of infection. If cells are present both in the anterior chamber and clumps of cells are seen in the vitreous also, this is surely infective. And if clumps of cells are seen in the vitreous with or without any of these signs, again it falls in favor of infection. Any haziness of vitreous is also infective. Hypopyon coupled with any of these signs will be infective, except when you have hypopyon on first post-operative day with obvious fibrinous exudates, right? Then that could be considered as inflammatory. My question to Dr. Dinesh is that out of this table, which sign or which combination of signs will make you definitely say that this is infective? Don't think about any other possibility.
The presence of vitreous exudates is the most definitive sign, and once this is in combination with a hypopyon, it's virtually pathognomonic of infection.
Lalit, based on what Dinesh has said, what will make you get out of your chair, enter the theatre and give an intravitreal antibiotic?
I'll get out, sir. But anything beyond this, don't hesitate to intervene.
Beg your pardon?
At this point, inflammatory can be considered. If it is a corneal pathology, I will take help from a corneal colleague and treat like a keratitis.
And otherwise, beyond 4.
Vitreous, along with any vitreous, yes.
Beyond 4, beyond 0.4.
Yes, it will.
You will inject antibiotic. Okay. Now, may I invite comments from Dr. Nayak?
Yeah, basically, this anterior segment surgeon should be always looking for if there are cells in the vitreous, cells in anterior chamber and corneal infiltrate. So combination of these three may be of any grade, because hypopyon is a different grade of the same extra cells. So if these things out of three combinations, means if there are permutation combination can occur, then they should be careful.
So message is that you don't have to wait till the vitreous becomes hazy.
No.
Presence of clumps of cells in the vitreous coupled with any other sign in the anterior chamber should prompt you to give intravitreal antibiotic.
Another point I'd like to make here is hypopyon does not mean a full 3 millimeter hypopyon. The earliest sign of a hypopyon is a blunting of the angle.
Yeah.
Just a little change in that curvature means you've got a hypopyon there.
Yeah.
Except that is less than 1 millimeter.
That we will show in one of the clinical photographs. Now the basic point is, now we have agreed that we have to intervene. Now intervention means from giving intravitreal antibiotics to going in a vitrectomy. Vitrectomy we are not considering at all here. So if you want to do, and if you want to give an intravitreal injection, what will be your choice? Now, any panelists?
I think the conventional.
All right,
even today,
I think I missed the bus. The point is, if you see the first slide on your left, there is the time when the patient presented. Then second one is the one where you see that you try to look into the fundus and you cannot see much. Meaning thereby what we have discussed is, if you can't see the fundus well, go in for an intravitreal injection.
This is how much post-op, sir? Lower one.
This is 40.